The thyroid gland lies in front of the trachea, where its isthmus overlies the second and third tracheal rings, while the lobes lie at the side of the trachea and larynx as well, reaching up to the middle of thyroid cartilage. There are three surfaces: the anterolateral in apposition to the strap muscles, the posterolateral in apposition to the carotid sheath and internal jugular vein, and the posteromedial in apposition to the trachea and larynx anteriorly and the esophagus and hypopharynx posteriorly. This surface has important relations to the recurrent laryngeal nerve, which passes anterior, posterior, or through a condensation of pretracheal fascia at this part, called the Barry's ligament, to enter the larynx inferior to the cricopharyngeus muscle. The thyroid gland is invested in the pretracheal fascia, which forms its capsule. Anterior to it, it is covered by the strap muscles, which are from lateral to medial, the omohyoid, the sternohyoid, and slightly deeper to the latter, the sternothyroid. The sternocleidomastoids overlap the lower part of the strap muscles. Anterior to these muscles is the investing layer of cervical fascia, then more superficial, the platysma muscle. Please revisit what you have studied in the physiology about the secretion of the thyroid hormones. The usual lab investigations requested at initial assessment of thyroid function are the free T3, the free T4, as well as the TSH. For follow-up of medical effects in the treatment of hypo or hyperthyroidism, only TSH survey is important. If autoimmune chronic lymphocytic thyroiditis, also known as Hashimoto's disease, is suspected, antithyroid antibodies are requested. Thyroid diseases are very common and more common in females. Goiter means enlargement of the thyroid gland. So we do not say goiter of the thyroid gland. We only say goiter because by definition it implies that the enlargement is of the thyroid gland. The types of goiter are described according to the shape of the gland, whether diffuse or nodular, according to its secretory activity, and according to the pathology. Certain combinations of these three descriptions are clinically named. For example, Graves' disease or primary toxic goiter means a hyperplastic colloid thyrotoxic diffusely enlarged gland. The endemic colloid goiter is due to iodine deficiency in diet and used to occur in some areas like the oases. It is seldom seen now because table salt became iodinated, and so the bread is also iodinated. Physiological goiter is a diffuse, mild to moderate enlargement of the thyroid gland at adolescence. It needs no treatment. Sometimes it persists as idiopathic non-toxic colloid goiter, or this type of goiter appears de novo at the age of 20s and 30s. There are small nodules less than 5 millimeters, and the whole gland is moderately enlarged. The function is euthyroid. A small dose of 50 microgram levothyroxine per day is usually prescribed to suppress further growth of the gland. Simple nodular goiter, also called simple multinodular goiter, is a disease associated with multiple colloid nodules of the gland. The patient is euthyroid. Simple means euthyroid. The nodules affect the whole gland, but sometimes are confined to one lobe. If there is only one big nodule and the rest of the gland shows only micronodules less than 5 mm in size, it is considered a dominant nodule and managed as a solitary thyroid nodule. Most simple multinodular goiters are benign, but 5% may show malignancy whether the history of goiter is recent or long-standing. Some patients refer for being worried about the nature of the swelling with no other symptoms. Most patients, however, complain of sensation of strangulation or some annoyance in breathing and swallowing. True dysphagia is, however, rare, and if present, should alert to the possibility of malignancy. Pressure symptoms because of tracheal compression may be due to a big nodule at the posteromedial surface or a unilateral enlargement pushing the trachea to the other side. Dyspnea, which is non-postural and rapidly progressive in severity, can occur with retrosternal extension. If there is no retrosternal goiter and the goiter is rather small, severe dyspnea, which is non-postural, should alert to the possibility of malignancy caused by tracheal infiltration or malignant pleural effusion due to lung metastasis. Similarly, hoarseness is rare, and if present, indicates malignant infiltration of the recurrent laryngeal nerve on one side. Meticulous history and full examination are complemented by some basic investigations. Basal hormonal assay should be done in all cases when diagnosed for the first time, namely free T3, free T4, and TSH. Cervical ultrasonography serves to assess the nodularity as well as the cervical lymph nodes. When biopsy is needed, ultrasonography-guided fine needle aspiration, preferably from at least 3 nodules, should be taken. CT neck and upper chest is done only for retrosternal goiter or extension and for clinically malignant gland. All patients to undergo surgery or patients complaining of voice change should undergo vocal fold examination by indirect laryngoscopy. Levothyroxine, commercially known as altroxin, can be given for patients with small goiters to suppress TSH and so to suppress the stimulation for the growth of the gland and further formation of nodules. For big or rapidly enlarging goiter, surgical removal is by subtotal or total thyroidectomy. A solitary thyroid nodule is a distinct clinical entity due to its high incidence of malignancy. To exclude malignancy, we need to know if the nodule is cystic or solid, and if solid, is it hypersecreting, hyposecreting, or of normal secretion. Ultrasonography is good in detecting whether the nodule is solid, purely cystic, or cystic with solid component. Cystic nodules can be aspirated and subjected to cytology. Solid nodules need radioiodine scanning to detect cold hyposecreting nodules which have a high incidence of malignancy. Although malignancy was also reported in some normal secreting warm nodules and in few hypersecreting hot nodules. Further management includes either surgery or ultrasound-guided fine needle aspiration and follow-up if the cytology is of benign cells. Follicular cells in the cytology, however, cannot differentiate between follicular adenoma and adenocarcinoma because the cells look the same. The malignant nature is diagnosed if adjacent blood vessels are invaded. Nevertheless, a true cut needle biopsy or core tissue biopsy of the thyroid gland should be avoided because of the high risk of bleeding that will lead to a cervical hematoma that might suffocate the patient. Hypersecretion of the gland or hyperthyroidism may be associated with goiter, that is to say, with enlargement of the gland, or can occur without goiter. There are two types of goiter in association with persistent hyperthyroidism, namely Graves' disease, where the goiter is diffuse, and secondary toxic goiter, where the goiter is nodular. The solitary thyroid nodule is a variant of the second type and described as toxic nodule. However, there are other goiters associated with transient hyperthyroidism, like de Quervain's thyroiditis and the early phase of Hashimoto's thyroiditis. Toxic nodules are usually benign, although might be malignant in rare cases. The following are the major signs and symptoms of thyrotoxicosis. Diffuse toxic goiter or Graves' disease is an autoimmune disease of the young patients, but can occur in the middle age. Immunoglobulin against the thyroid gland stimulates thyroid secretion. It is distinct from the normal pituitary stimulating thyroid hormone. For moderate goiter and toxicity, antithyroid medications are given for 12 to 18 months, but recurrence is up to 30% after stoppage of medication. Radioiodine ablation is a radioactive material taken orally and ablates the thyroid secretion permanently. A second dose may be needed if not the whole secretion was abolished by the first dose. The patient will need replacement therapy as levothyroxine, usually in a daily dose of 100 to 150 microgram per day, but maybe more, and is adjusted by serial TSH measurement. Radioiodine therapy could not be given with pregnancy because of its teratogenic effect. Also, the patient should be segregated, especially from children, for 1 week to avoid their exposure to irradiation from her body or excreta. Concerns were made about the carcinogenic effect on the patient himself or herself on the long run, so it was not given to patients under the age of 40 years. These concerns were not proved by studies, and many protocols now recommend this type of treatment for patients over 25 years old. Surgery is recommended for severe toxicosis or toxicosis with big goiter when radioiodine ablation is not desired, or for recurrence of thyrotoxicosis after stoppage of medications. Toxic nodular goiter or Plummer's disease, as well as its variant, the solitary toxic nodule, are diseases of the middle age and older. The toxicosis may develop over a long-standing simple nodular goiter, and hence named secondary toxic goiter. The severest symptoms are the cardiovascular, and if untreated, may end with heart failure. Medical treatment is only for control of toxicity preoperatively, because recurrence of toxicity is very high when the treatment is stopped. Radioablation is also ineffective and needs very big doses, except when the enlargement contains only micronodules 3 mm or less. This type is managed like Graves' disease. Therefore, surgery, usually in the form of total thyroidectomy, is the main and standard line of treatment. Toxic symptoms need to be controlled fully preoperatively to avoid a post-operative thyrotoxic crisis which could be fatal. Anti-thyroid drugs inhibit thyroid hormone production and secretion. Carbimazole is the usual drug used in Egypt and Europe, and methimazole of the same group in USA. Propylthiouracil is given to pregnants or those who become pregnant during medical treatment. Beta blockers, usually propranolol, is used to antagonize the peripheral effects of thyroxine, especially to control tachycardia. Carbimazole is provided as 5 milligram tablets, and the patient is initially given 30 milligram per day on 3 divided doses. The daily dose can be increased to 60 milligram per day to render the patient euthyroid. The effect takes at least 2 weeks because the half-life of thyroxine is 10 to 14 days. Agranulocytosis is a serious complication of carbimazole and presents initially with sore throat. Patients on carbimazole must be warned to stop the drug if they develop sore throat and to do CBC. Also, they are instructed to refer back for shift to another medication if pregnancy occurs. Propranolol is usually given as 10 milligram tablet 3 times per day in conjunction with carbimazole during preoperative preparation, or till the patient becomes euthyroid in long-term medication. When medical treatment is definitive, the carbimazole dose can be reduced to 15 milligram per day after the patient becomes euthyroid. TSH is used to monitor the response to antithyroid medications. When transient hypothyroidism is self-limited, as with de Quervain disease, the symptoms are controlled by propranolol alone, with aspirin as analgesic when the gland is painful. The role of corticosteroids in the treatment of Hashimoto's disease is controversial. Thyroiditis are a group of autoimmune diseases with inflammatory reactions. These are not due to bacterial or viral infection of the gland, but could be due to autoimmune response to a previous viral infection, like in subacute thyroiditis. There are mainly 3 types: subacute thyroiditis, chronic lymphocytic thyroiditis, and Riedel's thyroiditis. De Quervain thyroiditis is an autoimmune inflammation of the thyroid gland, usually following a previous viral infection 2 to 3 weeks before. The disease starts by pain and tenderness of the gland, followed by mild diffuse enlargement after 2 to 3 days. Symptoms of mild thyrotoxicosis occur mainly in the form of tachycardia and palpitation on rest. This is due to thyroxine leaking outside the gland. Thyrotoxicosis is self-limited, and the disease resolves within 4 to 6 weeks. Typical history plus a highly raised ESR are diagnostic. Antithyroid drugs are not indicated. Symptomatic treatment is given till spontaneous resolution. Non-steroidal anti-inflammatory drugs like aspirin and propranolol for the tachycardia are all that is needed. Corticosteroids are not indicated. Unlike subacute thyroiditis, Hashimoto's disease is a chronic persistent autoimmune thyroiditis due to the presence of antithyroid antibodies, especially antimicrosomal and antithyroglobulin. The main pathology is extensive infiltration of the gland with lymphocytes. Initially, there might be hypersecretion of the gland with thyrotoxic symptoms. Soon, the lymphocytes substitute most other cells and hypothyroidism develops. Hashimoto's disease is the most common cause of hypothyroidism. There might be diffuse mild enlargement of the gland. However, the nodular focal variant might be associated with nodular or even lobulated one or both lobes of the gland. This type might progress to lymphoma of the thyroid gland. Levothyroxine is the main treatment for life. Surgery is reserved for the focal type which might progress to lymphoma. Riedl's thyroiditis is autoimmune inflammation mediated by immunoglobulin causing extensive fibrosis of the gland. Fibrous tissue extends to involve adjacent structures. The whole of the front of the neck ultimately becomes a woody-like board with no separation between the gland, the trachea, and the surrounding muscles, vessels, or nerves. Thyroidectomy is almost impossible in advanced cases because of inability to separate the gland from its surrounding. When suffocation is present, division of the isthmus with or without tracheostomy is all that could be done. Corticosteroids might slow the progression of the disease with partial benefit. Follicular adenoma presents as a solitary thyroid nodule and should be differentiated from follicular adenocarcinoma. This is unfortunately not possible by fine needle cytology, and surgical lobectomy or isthmectomy is needed according to the site of the nodule. Metastases from primaries elsewhere are uncommon in the thyroid gland. Primary malignancies are more common. Lymphoma is rare compared to carcinoma. The four most common carcinomas are the papillary, follicular, medullary, and anaplastic in the decreasing order of frequency. Papillary carcinoma is a disease of children, adolescents, and young adults. It has a strong familial tendency and is directly related to exposure to irradiation. Multiple foci of the tumor inside the gland is very common, and lymph node metastasis to the deep cervical lymph nodes is early and is the main mode of spread. Total thyroidectomy is the main line of treatment which might be combined to lymphadenectomy of cervical lymph nodes. Radioiodine ablative therapy is given usually after total removal of the gland to clear up extragranular metastatic deposits. If the thyroid gland was not totally removed in the first operation, a completion thyroidectomy is needed for the radioiodine therapy to be effective. Thyroxine replacement therapy is withheld post-operatively until radioiodine treatment is completed because the TSH must be high. Later, levothyroxine replacement therapy is given, which also inhibits recurrence. Follicular carcinoma occurs in middle age and metastasizes preferentially through the bloodstream. The most common site of metastasis is the skull, and so the head must be bared and palpated during thyroid gland examination. It also metastasizes to the lungs and might cause malignant pleural effusion with dyspnea. Anaplastic carcinoma is rare. It is a disease of the old and elderly. There is very rapid growth and early spread with very poor prognosis. Excision of the huge gland is difficult, but is often needed to relieve the rapidly progressive dyspnea and stridor in association with permanent tracheostomy at the end of the operation if bilateral laryngeal nerves were infiltrated. Medullary carcinoma originates from the C cells producing calcitonin, and so there is no place for radioiodine therapy. Levothyroxine is given for replacement post-thyroidectomy, but not for tumor suppression.